This is our graduating cohort for 2025. They'll graduate on August 15th, so 2 weeks from yesterday. Nobody's counting down in this group, but I think they were counting down from day one. So, you know how it goes. You can get those types of calculators to let you know how much time you have left. So, controls, perfect. So yes, this is our group, and 15 strong, and we've had cohorts of 15 throughout the several cohorts that we've had. So this is our third cohort to graduate. We have 2 more that are in progress, right? So the class of 2026 and the class of 2027. We have the class of 2028 that's going to start on August 18th. So we're going to graduate these jokers on Friday the 15th, and Monday the 18th, we're going to have a fresh new crop of 15 more to come in. So this is our senior class. At this point, everybody's in the barn, so to speak, with getting their final programmatic threshold exam scores met. So we have certain scores, and I'll show you the course as we look at the progression plan. They've all met that threshold, so it's good news. They're all eligible for graduation. So the last one to come in score-wise was just yesterday. So said you have a whole 2 weeks to just enjoy anesthesia school with no responsibilities. So, but keep studying. So, because they have boards to take after graduation. Make sure this is going to work. Like I need to just click. Okay. So in overview, the program is a Doctor of Nursing practice degree. And I think it's worth a discussion of DNP versus DNAP. So one of you all write down that question and we'll talk about it in some detail later on. But in general, there are 2 pathways for doctoral degrees in nurse anesthesia training these days. So the Doctor of Nursing practice degree, and unlike my mother who said, "Oh, Aaron, congratulations on your PhD." No, Mom, I got a DNP, but she tells all of her card-playing friends that I got a PhD. I guess that's what they understand, right? So this is a Doctor of Nursing practice program. So it's based in a school of nursing. If you go to a DNAP program, that's going to be a program based in something other than a school of nursing, a hospital, a health sciences kind of general department. It depends on who the conducting institution is, according to the Council on Accreditation of Nurse Anesthesia Educational Programs, the COA. In our case, the conducting institution is the WVU, West Virginia University School of Nursing. So that's how our program is developed. There can be pros and cons to how those are how those different programs are laid out. I don't have a lot of intimate knowledge on DNAP programs, but perhaps you've done some investigation. I'd be happy to have a conversation about that. That's why I wanted you to bring it up a little later, if any of you have done any investigation along those lines. However, our program credit load is 88 credits, a graduate education, okay? You have a full-time, okay? So full-time means that you cannot attend in any part-time fashion, okay? We have courses that are offered once a year in sequence, and we can't offer multiple courses. We can't offer the same course in multiple semesters in a given year, okay? So if for some reason you needed to repeat a course, you'd need to wait a year to take it again, okay? Hybrid, what does that mean to you guys? What does hybrid mean? Yeah, a mix of online and in person. So most of the anesthesia courses are in person, though we have transitioned to having a lot of online capabilities. And we are classified, if you would look at us, I believe on the COA website for nurse anesthesia programs, technically we're classified as an online program, but that means just greater than 50%, in our case, 52% of our courses are offered online, okay? And it's an integrated curriculum. So an integrated curriculum means that we give you the anesthesia knowledge that you need to know when you need to know it. We are not front-loaded. That's in contrast to being front-loaded, where you get all of your anesthesia teaching up front and then go off to clinical for the next 2 years or however the curricula are set up. What's been most interesting to me in my role as a program director is realizing just how many different ways you can run an anesthesia program. I will tell you about how we run ours today. Yay, we got accredited. On June 17th, we found out about a 10-year accreditation. So we're good to go for 10 years. And so 2034 is the next time we'll start writing up a self-study and anticipating a visit in the fall of 24 with a decision again by the COA in 2035 to see if we get another 10 years. But the Council on Accreditation of Nurse Anesthesia Educational Programs is the accrediting body for nurse anesthesia educational programs, whether they're DNP based or DNAP. We all have to meet a set of 200 and some standards through 8 different broad categories of accreditation that meets the minimum standards that all nurse anesthesia programs need to meet, okay? And we were deemed meeting all of those by the COA and at their meeting in May and got a letter on June 17th. Our cohort is 15. We did apply to expand to 20. So you may have heard that in some conversations if you've been paying attention to the program. We just need to have more faculty resources, but frankly, I think a lot of the students that are here prefer a smaller cohort, and perhaps you do too. I mean, honestly, I do too. I'd rather manage 15 per cohort than 20, but there's also a need across the sidewalk at Ruby, where we'll also visit here today, to hire some, I think, I'll be conservative, but probably 25 CRNAs. I think the need is actually higher than that. So yeah, so what we do graduate 15 per year. Our current graduates are 3 are staying at Ruby, another 3 are staying at other sites throughout the state, so a total of 6, but 9 others are going to other places, such as several sites in Virginia between Richmond, Charlottesville, and another town. Another person's going to Florida, another person's going back to Texas, and so forth. So there are folks that stay, there are folks that go back from whence they came. So that's kind of how the breakdown is. And we've averaged about 6 to 8 staying either in Morgantown or in the state over the first 2 cohorts. Okay. As far as faculty, so you met me, Dr. Ostrowski, the program director. Most students call me Dr. O. It's just easier. But it's easy to spell. OST, row your boat and ski down a hill. It's kind of how I tell the people. And but fun fact, I've adopted my middle son's nickname that he adopted for himself, Steve, because it's easy when you give your name at Chick-fil-A or Starbucks for them to spell it on the monitor, to announce it, to hear me say it, and for them to announce it. So like, that's a winning nickname. So that's my alias. My middle name's Michael, but my alias is Steve. So yeah. But program director, I've been here since 2017. I developed the program, the curriculum, whatnot. You'll meet Dr. Frame on the next slide. He was an assistant program director for the first 3 years of the program. we both worked our fingernails off at the keyboard and or got our voices in hoarseness mode by writing out and putting meat on the bones of the curriculum that we developed for the first couple of years. We actually, put course schedules together and lectures together for those first several years, and it was quite a lift at that point. But we had our first cohort come in spring of 2020, and so we have a member of our first cohort here today. Dr. Carrie Roskowinski was her maiden name when she was here. And Carrie, what's your married name? Adams, Carrie Adams. But she's still Roskowinski in my phone. So, but Carrie was a member of our first cohort. She was the fearless first 15, and they still are the best cohort to come through the program yet. So, but personally, I've been in practice since 2002. So after that information session, I went through the University of Pittsburgh's nurse anesthesia program, graduated in late 2001 and practiced starting in 2002. And I've been really on a guest lecturing basis since I graduated. I worked at Pitt and got involved more deliberately in student education in 2008 with Pitt, and then came here in 2017. So I've been here since. And then Dr. Miner, Laurel Miner, she is our assistant program director currently. She has been the director just since 2025. She has had that prior role at another institution, so she comes with that experience already. She's been here since early 2024, so she's been in practice for longer than I have. I looked at her, so our AANA numbers are kind of sequential, and so the lower the number is kind of like the more mature that you are. And so I'm covering up so to feign like I'm not recording it, but she's gonna hear me out. But she's been involved with nurse anesthesia education since 2018, and she's been a nursing educator for years and years. And her PhD is in nursing education. So she has been an extremely helpful person to get our evaluation program in order, which is one thing that when the COA did come last fall said, this is one thing you guys need to work on. So, and then Lissy, most of you guys met. She's at the back of the room. Lissy Saminsky is our administrative associate. So she's going to be a presence that students will have interaction with on a regular basis. And then we have members of our 2027 cohort at the back and on the side, so you guys can raise your hands. So they are exactly 2 years beyond you sitting in this seat right now. So they just completed their first year of anesthesia school and will be now considered juniors and not firsties starting August 18th, okay? Our other faculty, so I mentioned Dr. Mike Frame. He was our inaugural assistant program director, and he's been in practice since 2004 and has been involved with nurse anesthesia education since 2017. And then more recently, we've had a position called academic CRNA developed with Ruby, whereby CRNAs who are still employed by the hospital are given time to come and teach and be part of nurse anesthesia faculty. So it's a way to kind of foster the future of the program, which is something I always have an eye in leadership for succession planning. I don't plan on leaving next week, next year, or the next 5 years. I don't know when, next 5 years. But I always want to keep in mind that we need to foster this program's future health by training excellent CRNAs that can practice here, but also excellent CRNAs that have an eye for giving back to the profession through education and whatnot in the future. Jen could be one of those. So she's the academic CRNA. She has a 0.8, it could be 0.6 practice position because we might increase her FTE to come over here. She's 0.2, could be 0.4 on the academic side in the near future. She's been lecturing with us since May 2025. She's going to present actually her first lecture to the senior cohort, their final day of class on Monday. She's pretty techy, so she's going to talk about anesthesia equipment, and it's been a presentation she's putting together over the last couple of months. She approached me and said, I want to teach in this program. She lives in Westover, which is a nearby suburb of Morgantown. So she'll be here for the long term. So a little bit more about the hybrid curriculum. As you guys mentioned, it's a mix of online and in-person classes. So the 30 credits of core DNP courses are a component of that. 37 credits of face-to-face anesthesia courses, so anesthesia specialty or anesthesia specific courses. So what would you guys expect by seeing core DNP and nurse anesthesia on separate lines? Think about what would be in those courses. Are there going to be anesthesia topics discussed primarily in the core DNP courses? Or are they going to be primarily in the nurse anesthesia courses? Yeah, right. So, I mean, it's an obvious question, but it is I just bring this up because it's somewhat of a point of grievance about our curriculum, and this will be a point of contention for, I would venture to say, any DNP program that you look at, that the core DNP courses are necessary because of the structure of the school of the nursing driven program. So we are teaching courses that are based on essentials in graduate education for graduate nursing programs. Okay. DNAP programs, I don't think, this is a good question to ask them if you're looking into them, are not wed to those essentials of nursing graduate education. Okay. So that's one thing I want to put out there, because feedback that I get from our students I met with 10 of them graduating, yesterday I met with 10 of the upcoming graduates through, 30, 45-minute Zoom sessions to go over their graduate checklist and get their feedback in person. I, said, so give me something you liked about the program and one thing you'd like to, see improve. And several of them mentioned like these core DNP courses, they got to get more anesthesia content in them. And I'm here to tell you now, before you apply to this program, that in speaking with the COA, the folks who say this is what your anesthesia program should teach, they said in one of the follow-up curriculum questions to me, does your general pharm course, because we have 2 of them, we'll show it to you, does your general pharm course talk about anesthesia at all? And I said, well, and I'm thinking they wanted to hear, yes, we talk some anesthesia, but what it is we have a couple of guest lecture spots where I come in and Dr. Frame comes in and have a couple of literally an hour each over a 45-hour course that over 15 weeks. We talk about a little bit about narcotics, a little bit about anesthesia medications. And when I said, yeah, we have a couple of hours that we contribute to this pharm course, he's like, is that all? I'm like, yes. He's like, good, because you need to have a pharm course that covers more general pharmacology and not anesthesia specific. So, and there are other core DNP courses that are, not the most fun for our students. And I think that somewhere in the middle between meeting what the anesthesia students want to see and learn in those courses and what is taught in those courses could be, maybe a happy medium met at some point. But I do want to kind of let you know, like right up front in this info session and right up front in the admissions process, that when and if you become a member of this program, I'm going to say, remember when we talked in the info session? This DNP program is going to make you the consummate graduate nurse that also can give one hell of an anesthetic. Okay. So I just want to make sure that I give you the full meal deal on what a DNP program is like. With that said, 37 credits of our nurse anesthesia program is face-to-face in several online anesthesia courses. Dr. Frame teaches primarily remotely. So he has 3 or 4 courses that he teaches that are anesthesia specific, peds OB, pharm, anesthesia pharm, and chemistry and physics. So those are his courses that he teaches like solely online. So you'll see like a little asterisk on our progression plan that indicates that those are online courses. Okay. Then there are 15 credits of clinical practicum courses. You'll see that how those are budgeted throughout the program through a few slides. And then we have 6 credits of DNP project courses. This is a question to ask of any other program that you're looking at, that are there budgeted times for students to complete the DNP project? What that means is that you have time in your curricular schedule. I have time budgeted to my workload to work with you on these DNP projects, because we'll talk about what a DNP project is. It's not a small slice of the pie. You will spend some time on it, but it's a very productive process if you trust it. Right, Carrie? I say trust the process, and from day one, and it'll get you there. In the blocks here, you have the core DNP courses highlighted. And so you notice that if you look at the first 2 semesters in year 1, we have a total of 6 courses, 3 each. Okay, that's 6 of the 10. And those prepare you to get the DNP project started. Those give you foundational principles for pharmacology, for health assessment. I don't know if this pointer is gonna, nope, never works on the screens because of the coding. But so Foundations of Leadership was a course that we actually switched to this semester just in the past year. We kind of cycled several courses around into different spots. And this was one that was going to prepare students better for the DNP project, to have some tips on how to be a leader and interacting with the clinical sites that you're going to do, that you're going to interact with when you do your project. Advanced Pathophysiology is a course that introduces patho. It satisfies our needs for anatomy, physiology in the curriculum. And it's a course that the nursing and COA wants is called the 3 Ps. So if you've done any investigation of graduate nursing education, patho, physical assessment, and pharmacology are the 3 Ps. So our physical assessment is in semester 2, advanced lifespan health assessment. But back in the first semester, you have another course called Scientific Underpinnings. The DNP prepared a PRN. So that's gives you an idea of what our essentials, our curriculum means in your education. Advanced Pharm was the kind of general pharmacology course for graduate nurses that I have mentioned. And then evidence-based practice methods gives you a framework on which to build your DNP project. And that actually, you can get your DNP project started in that semester. And I'll talk a little bit about that. Our goal as a program is to give you solid leads, solid ideas on what to do for your projects. A lot of times those have to get tweaked a bit. Certainly, if you come with an idea that is viable, we'll try to nurture that and make it work with a clinical site that you could have a partnership with. And then clinical data analysis and visualization will be a new course that replaces what used to be called statistics. But in evidence-based practice, there really needs to be a different approach to data analysis. And so this course is going to do that. Okay, so that's a new course that was developed, used to be in the first semester, but we kind of placed it with the courses where you're actually starting the project in earnest. Okay, the next DNP core course is informatics, so that satisfies another essential, and then population health promotion in year 3, and then advanced practice nursing issues, ethics, and policy in the 9th semester. Okay, so those are the core DNP courses. The nurse anesthesia courses are also spread throughout the curriculum, of course. Our first course is overview of the nurse anesthesia profession. So we introduce you to the organizations that kind of govern your profession. So the COA is one of them, is the Council on Accreditation. So that really is specific to programs, but it does have influence on the rest of your career. Then the NBCRNA is the National Board of Certification and Recertification of Nurse Anesthetists. That's another organization that we introduce you to that kind of is based on your initial certification, you'll recertify with them every 4 years throughout your career. At least at this point, it's every 4 years. It seemed to have been changing over the last decade here and there. And then, of course, the AANA, the American Association of Nurse Anesthesiology, is the third organization. So we'll talk about the profession and get you introduced into the roles of a nurse anesthetist in this course. Then genetics, chemistry, and physics, somewhat self-explanatory. Then you go through a series of basic and advanced principles courses. So basic principles 1 and 2. We teach you how to do general anesthesia in basics 1, teach you how to do regional anesthesia in basics 2 for like spinals and epidurals. We have advanced courses that teach you peripheral nerve blocks later on. And so our whole curriculum is programmed to be from a basic to more advanced pathway. So you learn the basics early, and then we build on that as you go through. Okay. Again, integrated, meaning that clinical, we'll show you, clinical starts in this semester, no clinical in these first 2 semesters. And as you need to know things with your advanced skills, you learn them. Okay. Advanced pharm. So for pharmacology of nurse anesthesia is here. Advanced principles courses and perioperative assessment and care. This is a course in which we teach you how to put in central lines, how to do point of care ultrasound assessments. So abdominal, thoracic, and airway. And we have a business course. Okay, so business management and finance and nurse anesthesia practice. So that's a course that we have here. We also have a professional issues course 740B. So 740A and 740B are kind of like the bun to get you started with a sandwich that's the high protein that you have in the year 2. And after you go through several clinical practicum courses, you start to see like some pieces of the puzzle in nurse anesthesia. And you're like, I have questions about this or that. And that's what you can bring to the table in professional issues 740B. Okay. Business of anesthesia. And then this final course is what I talked about our seniors getting through, where all of them have met a threshold score. And 751 is the evidence-based anesthesia review. We take a board review program or curriculum that's called APEX. Some of you may have heard about that, but it's something that we recommend you getting early on in the program by like semester 2. And we incorporate lessons from APEX throughout the curriculum There are certain exams that are called, password protected exams that we have to proctor. We give those to you, and there's loads of them. And from the first cohort on through this one, we've been tweaking this course probably the most to help meet the needs for us to improve our first-time pass rates. So does anybody know our first-time pass rate for our first cohort? It was 80%. In our second cohort, 87. So I want to see better than 87 for this group. So I'm telling them, like, let's do it, folks. So we'll see what happens. But there's so many factors to control for. It's not just knowledge, right? Who gets nervous taking a test? I mean, me too, right? So yeah, it can kind of put you on edge. So there are things that we do to beyond just giving you the knowledge. In this course, we give you test taking tips and like relaxation strategies and all those things. So, because we get it. So then I'll step out here a minute and just talk about the DNP project. So the DNP project it's integrated into the program, but it's also can take you out of like doing your actual anesthesia coursework, where you have to pay attention to this process of developing a project that speaks to a problem in the practice environment. So the projects can be quality improvement, policy analysis, evaluating some program that's already in place, among others. And assessing the practice environment is something that you can or may not have to do depending on, kind of what you come into the course, into the curriculum with. Once you assess that, you can determine if there's any variances from national benchmarks or best evidence. And like through our evidence-based practice course, we'll teach you how to search the evidence for the best practices. And then through a development course, through an implementation series of courses, and through presentation, you finish your project. But you can initially refine and address a practice problem. And this is probably where some of our current cohort folks could speak to once we I give them the mic. But our objectives for this is to have them critically appraise the existing literature. So the purpose of a DNP project is not to do research. It's not a study. It's not generalizing knowledge when you write up your manuscript. You're not inventing something new. What you're doing is you're taking the research that's been done and published, finding the best information that you can use from that research to apply to a problem that Ruby is having, that Mon Health is having, or whatever hospital that you could be involved with is having. And you can develop a real solution to help solve their problem. So the initiative is going to address that practice problem. You get approval from the school, from your committee. It involves 3 people. It's you, it's a faculty of record, which can be a nurse anesthesia faculty or another doctorally prepared faculty person in the School of Nursing. If you have a non-CRNA FOR, they're called faculty of record, you have a CRNA on your committee, and then that is your committee for your project. You implement the project based on what you develop as a proposal. So our 2027 group is in the proposal phase right now. This fall, we will go through a series of steps to get their proposal approved, and then we'll evaluate the outcomes. They'll collect data based on information that they collect and evaluate those outcomes, and then write up a manuscript. And then in the final semester, present those outcomes. So things that you want to ask when you're looking at another DNP program or a DNAP program is that because even if you go to a DNAP program, it's a Doctor of Nurse Anesthesia Practice, you still have to do a doctoral project. What you want to ask is, what qualifies as a doctoral project in that school? When does it start? When does it finish? How much time is dedicated in the curriculum to the work? And how are the project ideas generated and vetted? And what is the advisory process? So I'll answer those questions for you for us. What qualifies is some type of project that leads to an organizational change. Now, organizational can mean system level. Organization can mean hospital level. Organization can mean unit-based, okay? So it can be on several scales. We've had examples of all three thus far in, from our first 3 cohorts. And you need to implement something that is going to make a change, okay? We're still kind of wrestling with whether something in simulation can count as a change. I'm a proponent of that. We do a lot of simulation in this curriculum, but whereas our simulation is more for learning, we can also do it for evaluation, say of professionals who have been in practice. But what's a simulation course that maybe you don't think about as being simulation that you have to do every 2 years? ACLS. So your AHA certifications, okay? You probably have to do some element of practicum in addition to knowledge measurement to see that you can do a code, right? Yeah. All right. So when does the doctoral project start and finish? So starting and finishing is important. We try to start the project early so that you can get it done and focus on finishing your hours, your clinical hours, and getting ready for boards, which is what our seniors have been doing. And now, like I said, they're all on board, ready for graduation. Ideally, our project should finish with like 2 semesters free and easy for just clinical practicum and board prep. It doesn't always work out that way, but the other piece of that is those 2 freer semesters at the end give you an opportunity that if you get some unavoidable delay in your project, you're not staying here after graduation to finish your project. You're getting it done in those final 2 semesters. So it's kind of built in time like that. And then how much time is dedicated in the curriculum to doctoral work? I'll show you that on the next slide. We have courses built in throughout the program where you have time to work on your project and your faculty has time to meet with you, okay? How our project idea is generated and vetted, like I've already alluded to. You come to us with an idea, and a lot of times we have ideas from our clinical partners in the program. And then the only thing that would be of any change in the recent past from previous cohorts is that we do have to declare some relationship to anesthesia impact. How does this project apply to anesthesia practice or education or the profession in general? Those are the requirements for the COA and our DNP projects. Then what is the advisory process for the project? I've already told you kind of about the team, the committee that's developed. It's a faculty member, it's a student, and the person I didn't mention would be a clinical champion at the site. That would be another person that you would want to have on board. So all of these folks with their projects have a clinical person that they're working with who is vested in getting this project off the ground. Okay. So these are the locations of DNP project courses specifically. The courses that I mentioned in terms of evidence-based practice and whatnot, and then the co-requisite of clinical data analysis and visualization, that 829 course. They are courses that prepare you to do your DNP project, and as you're writing your proposal, give you advice and guidance on how to fill in certain sections of the proposal. And then the DNP project development, you see in 1 semester, that's a 2-credit course that our students are going through right now. They've presented some of their proposals in a PowerPoint during class, and the professors give feedback as a group to say, this is how you could tighten up this part, this is what you could do to improve this part, and this is great, keep this, so it's live feedback. And then DNP project implementation 1 and 2, they're 1-credit courses that you could smash together. If your project is on lightning, greased rails, and it's going to get done really quickly. We've had a couple of students in the class of 26 with projects like that. And same thing with the DNP project presentation. You could either space that out over 2 semesters and complete your manuscript and do a presentation. The third thing you have to do in that course is write a portfolio, and how like all of these courses that you've taken help you meet essentials of the profession. And so there's time built in for that. Clinical commitment. For the COA, they require all programs to have a minimum of 2,000 hours, 650 cases, and a minimum 80% first-time pass rate. Now, kind of smashing all these together, you can see hours and case numbers for our first 3 cohorts. So 2022, 24, and 25. What's kind of missing there is the class of 23, but in reality, the class of 22 was going to be the class of 23, but our dean wanted to move the start of the program up from August to January. So they enrolled in January of 2020, basically 8 months ahead of time. So you're welcome. You got 8 more months of income as a CRNA, Carrie, so to pay off those loans. But yeah, so the 22, 24, 25 cohorts are the only 3 that we have. So you see a slight downturn in the number of cases for the most recent, but really above 800, I'm happy with that. And then our first-time pass rates, since our 3rd cohort hasn't graduated yet, we don't have a first-time pass rate to calculate yet. Okay, those are the stats. These are our clinical sites. So one thing you're going to have to be aware of is that you're going to be a traveler if you're a student in this program. You don't have to go to all of these sites, but there are 21 on this map, 21 stars. And our most recent site that we've added is heading kind of directly northwest from Morgantown, in the center is Wheeling Hospital. And it's a WVU medicine site. It's going to be a great site. We're in the process of getting approved from the COA of using this site for our students. They're excited to have our students go there. I went to nursing school with the chief CRNA, not CRNA school, but nursing school with the chief CRNA there. So like we're going way back. And then a couple of other sites that we're going to add are also in the southern portion of the state. Thomas, which I think is kind of in Charleston proper. And Weirton, which is also on the northern panhandle, kind of close to where Wheeling is. So yeah. Now, if you all want to build another like couple dozen hospitals within 20 minutes of Morgantown, hey, let's do it. I'd love to have, nobody have to go very far for the clinical experience. However, that is just not the nature of West Virginia. And that's part of the mission of this program, is to, there was no program here before. There was this academic medical center right across the driveway, right? What we're sitting in is what used to be kind of the academic institution, but the hospital was Health Sciences South, which is the tower that that we'll tour through. This dispersion of our sites is really kind of the crux of the problem with West Virginia being kind of like one of the better places to live in the country. It is a best kept secret. If you come here and haven't been here before, and you just venture an hour and a half radius around this town, there are some incredible, natural wonders to see. So, it's something that you would want to, embrace if you aren't familiar with the area. But that said, it's tough because there are a lot of hills and dales that you have to kind of go up and around and through, and potholes and whatnot. And it's just the nature of the beast. But bottom line is, where these stars are, people need you. And they need us. So that's why we have this program. So the clinical practicum courses start in semester 3. And you can see that in red, the hours associated with each semester. And those are minimum hours. I'm always happy to see students exceed the minimum. we emphasize that these are minimum hours per semester. And, but those correlate with the credits allocated in each semester. The only outlier is this first semester on top right of 60. That's just our typical ratio is 150 hours per credit. And we do that because if you look at other programs, they have different ratios per credit. This is where a program can have, you know, an extreme amount of cost associated with the credit load. Okay. Speaking of that, we have preparation for clinical through multiple simulation experiences weaved throughout the curriculum. And even beyond the 743 simulations at the top, we have an introductory airway experience in the first semester to help, you know, kind of remind you that, yes, I know that you're taking all these other courses, but you are in an anesthesia program, and, you know, here's some time with some mannequins and stuff, and we'll teach you how to intubate. So, and do a couple of other things. And we have some other ideas of how to improve that intro experience as well. But this actually happens to be Carrie on the left in her mock induction simulation when she was a student in the program. And we were learning how to send patients off to sleep, right? We prepare you for this before you enter clinical so that you kind of know what you're doing and get you started. But as you go on in the program, you'll learn how to put in central lines. So that's one of our first cohort members, Megan, putting in a femoral arterial line. And these are just other members from our first cohort. So I didn't include any pictures with names on them, and that's I didn't want that to be, you know, going out to public. So, but here are some faces from our first cohort. So we spend a lot of time in simulation in the lab. Then we also encourage professional meetings for both the West Virginia Association of Nurse Anesthetists and for the professional national organizations as well, the AANA. Okay. Probably the slide that you all want to see to kind of know what you're getting into. So this is not a cheap endeavor. So resident and non-resident tuitions at this point for these are updated tuition figures. If you look at the tuition total, it would be about $114,000 for 9 semesters and $196,000 for tuition for out of state. Then we declare a bunch of additional fees that include the laptop program, AANA membership. APEX is the review course that I mentioned that we use throughout the program. Typhon is a case and time log tracking software that we use. PreCheck Sentry MD is an entity that you upload your credentials to show AHA certification and et cetera. The Nursing 705 course, we've added that fee. They have an additional program they want you to purchase. Then the C is the self-evaluation exam. That's what that stands for. The C is one of the, we have you do it in one of the fall year 2 courses. And in preparation for your last year, it's a self-evaluation exam that lets us see where you are, what you've done and learned in the program thus far. Then we say there is an option to repeat it as a way to meet the threshold for graduation in the final semester. So you may take it twice. Then there's other associated expenses. I would say, you know, what can be variable in here would be your health insurance. If you are otherwise insured on parents or a spouse or some other resource, you can avoid that $12,000 fee because that's what the university charges you and for students. And it's something you have to opt out of every semester with your tuition bills. Is that correct, guys? Yeah. So something you have to update each semester. Then the lab fee is steps. That's what they charge per student per semester to do simulations. So we make sure we have simulation every semester to utilize that. And then clinical site housing would be the other variable that could be on here. I think you could spend 0, you could spend 1,000, you could spend 15,000 in that area, but that's going to be what's going to be really according to your lifestyle. Okay. This is another important slide for you to kind of ingest, the time commitment. So there's a combination of clinical, class, and study time. How much does this really take? And so I think that this is where our current cohort members and graduates can chime in. But if you kind of calculate this out, it really works out to be close to a couple of full-time jobs when you're really in the meat of it. It's not like this from day one. I would say in the first couple of semesters, you could probably maintain employment if you needed to. But when it comes to semester 3 is when you'd probably have to curtail that and really start focusing on nurse anesthesia, school and be all in. Okay. Admissions are spelled out on our website. This is just copied and pasted from there. We don't require you to get PALS before you enroll, but once you're enrolled, you want to take PALS before you start clinical activities. So you have like those 2 semesters where you could be working, you're taking online courses. I would take PALS sometime in one of those 2 semesters to prepare for clinical in the 3rd semester. But everybody will go through an interview. One important piece of the admissions is eligibility for admission to WVU. What that means is that not only did you go to a nursing program that was accredited, but you went to an institution that was accredited. So just as programs need to be accredited, WVU needs to be accredited by the Higher Learning Commission. I didn't know what that was before I started here, but we've had applicants apply and their program was accredited, but their institution wasn't. And it's like, we can't admit you because the university is beholden to that standard. So you can look up, well, I don't know if you can these days, but it was the Department of Education. If you look at that up, .gov or whatever it's going to be, you could look up accreditation and just maybe type in your institution. You should be able to kind of Google that and get to that pathway just to make sure that your institution was accredited, or call them up. Admissions process is going to be a slightly different this year. So who has kind of tried to find the application is like, it's not working. It's true. So it's not your fault. Remember talking about having to log into a bunch of different things? Well, another symptom of that is that our admissions applications they've elected to shut them down for the month of August to get this new system up and running. So we've been told that our applications aren't going to open until September. September 1st? Oh no, they're going to let us know. So as soon as, what I would say is just let, Philip know. I think most of you have been in contact with Philip Engelmeyer. And so let him know that, you want to apply and to let you know when the application window opens. Okay. So as far as when applications will close, we've had a closure date in the past of like November 1st, but since this September issue has come up, we'll push that back. And besides that anyway, we've kind of pushed our entire admissions process, delayed a little bit. Instead of having Zoom interviews in March, nix that Zoom interviews with faculty, dang it. We're going to have in-person interviews in probably March or April. So I've missed that Zoom on there, but we're not going to do Zoom interviews. So I'm done with the pandemic. We're moving on. So I much rather see you face to face, talk it out, and there's just a lot of peripheral learning that can go on when we're person to person. So that's the admissions process. And then the last is what makes us different is reduced barriers to admission. We used to have a GRE, we don't anymore. We don't really have any course prerequisites. I might start looking at some science GPAs, but that's not official. Just casually and correlating things. PALS after admission, mentioned that in the first couple of semesters. So just to reiterate, there are no course prerequisites right now, and you will not be held to those. We have smaller cohorts. Even if we went to 20, that's still a smaller cohort. But that's all this program director is gonna do. I'm not gonna do more than that. If they want 50, they're gonna have to find another guy. So passionate faculty. Hopefully it's evident to you that I care, and perhaps throughout this process that it will be evident. Then the early DNP work. You also have a close relationship with your faculty of record through the process. I spend time with my students as they need it. There are some that we meet more than others. It's not due to ability or lack thereof or whatnot. It's if they got their act together and they don't care to meet, that's fine. If they don't have their act together, I'll be contacting them and saying, let's meet. So that's how those things can work. And then you will develop the full scope of clinical training. Another piece that I wanted to mention about clinicals is that with all those stars, because they're in more remote locations and access to care is more difficult, those are also locations where there are CRNA only practices. So this is a curriculum where you'll get, if not a CRNA only practice experience, you'll get a supervision model experience where there's much more freedom and latitude given to the CRNA's judgment and care of the patient, rather than a team model in anesthesia. So that's the full scope of clinical training. Will you'll get it here. And as I say to students on the first day of enrollment, the benefit that you get out of this education will be your own motivation. I will meet you there. I'm motivated. But if I'm not feeling it, I'm not going to necessarily pull you out of it, So if you want to do some of the crazy things that we can do and teach you in this program, I'll give it to you. But if you're going to be like, then okay, then I will kind of let you be, So I'm going to meet you where you are. You're going to have to meet the requirements, but if you want to meet and exceed, I'm there for you. Okay. So at this point, I'm going to open the floor for questions.